Good afternoon, everybody, and welcome to another one of our fantastic webinars in our webinar series from the Florence Nightingale Foundation. I'm Lucy Brown, I'm the Director of Nursing and Deputy Director of the Academy, and I have one of the wonderful parts of my job is to host the webinar series at the FNF, and we're absolutely delighted today to invite Dr. Emma Wadey, who's joining us this afternoon to share her expertise. Emma, congratulations first and foremost, because I believe you've just finished your PhD, so many congratulations, and it's great to be able to welcome you as doctor, so well done, very well done. Just some housekeeping before we get started. We will be recording, as you heard earlier, recording the webinar, so if you have any issue with that, please do let us know. It will be available in a few weeks' time, just have to get some checks done first. We will be having a Q&A session at the end of today. And what we would like you to do is just pop any questions you have in the chat box and I can ask them on your behalf. Slightly different setup than usual, so do pop any questions you have in the chat box or any comments you would like me to ask. Just a bit of background on Emma. Emma is a really experienced mental health nurse with over 20 years experience and expertise, really focusing on suicide prevention is one of her main areas of specialty. She's worked in emergency care, in criminal justice systems, and also within local psychiatric community services as well. So it brings a wealth of knowledge and understanding. And what's really fantastic is Emma's also a Florence Nightingale alumni, one of our previous scholars. And her current post, she's Deputy Director of Mental Health Nursing at NHS Improvement in England. So has great impact on policy. And hence where we've come to the topic of today's webinar is Emma will be sharing her expertise on how to influence global policy. So without further ado, I'm going to hand across to you, Emma. Thank you so much for joining us this afternoon.
Thank you so much for that introduction, Lucy, and welcome everybody this afternoon. Now, I'm going to probably show you how inept I am at anything technological by attempting to share my screen so you can see the slides. Hopefully the slides will be with you very shortly, although I tend to like pictures rather than words, so how much use they are to you may not be as useful. So just a couple of things that I want to cover today. So Lucy's already introduced me as the Deputy Director of Mental Health Nursing for NHS England and Improvement. And I'm also going to spend a little bit of time in this webinar giving you an overview really of my role currently and career to date. A little bit about what policy is and what shapes it, a bit of a refresher for most of you. I know that having looked at the attendance list earlier that there will be many of you that are far more expert than I at this. So I would say I'm an interested novice in terms of global policy, but I will be sharing with you my personal and professional experiences of influencing policy development, both locally, regionally, nationally, and also internationally. I'm going to just reflect a little bit about the global perspective and just give some examples of how we are already in England shaping our healthcare systems in response to international and global health, particularly around good practice. And then I'm going to share two examples of how policy has been put into practice from my own career perspective. One, an international perspective, and one slightly closer to home in terms of the rollout and implementation of the professional nurse advocate role. So my portfolio, and it was quite hard to squeeze it on the slide because I've held multiple roles actually just in the course of the last 2 years that I've been in post as the Deputy Director of Mental Health Nursing for NHS England and Improvement. And what you'll see right at the top, and I'm going to talk a little bit more about that in detail as one of my examples around global policy into practice, is that I am a member of the technical advisory group for the mental health collaboration for the World Health Organization. And I'm going to share with you how that came about. And it's worth noting, particularly as this webinar is around shaping and influencing as nurses and influencing wider healthcare as a nurse, that actually I am the only nurse represented on that technical advisory group. My portfolio with NHS England, as you would expect, as the Deputy Director of Mental Health Nursing, means that I have a responsibility and I'm accountable for contributing to developing, influencing and implementing workforce policy and practice. And some of the ways in which I've done that most recently, and something I'm very committed to, is growing the influence and opportunity that all mental health nurses particularly, but nurses have in shaping some of those decisions, if not all of those decisions, in terms of policy practice and how we ensure that the people, the patients, their families, their communities get the most from the services when they need it. So some of the examples of that, which again, I will talk about later in terms of how I've been able to influence policy and how important having this infrastructure in place has been developing a mental health nurse shared decision-making council, reinvigorating a mental health nurse consultant forum, participating and contributing and leading around mental health nurse international recruitment, supporting mental healthcare support worker programme, and ensuring and thinking about access into mental health services for all workers, but also thinking about the skills and the support they're needed once they're in post. And unfortunately, we know that there is a global shortage of nurses, and we know that particularly there is an issue with mental health. We have around 25% of mental health nurse posts are currently vacant. And we also know that although we're doing fantastically well at recruiting new recruits, so new potential aspirant nurses and aspirant mental health nurses, it can be harder to hang on to them and support them once in practice. So again, another big piece of my work, and probably one of the things that keeps me most anxiety and stops me sleeping at night, is thinking about how we best support the workforce. And again, I'll talk about that in a little bit more detail. So another area of my role, so it's the mental health nursing professional aspect that I've just mentioned there, but also I'm the nurse lead responsible around the mental health of the nursing workforce. And particularly there are a couple of areas that I have led on in the last 2 years in response to that. One of those is the development and implementation of professional nurse advocates, which I'll talk about as one of the policy areas examples later. And the other is the prevention of suicide in nurses and midwives. It is a horrendously sad fact that female nurses remain the highest risk professional group from suicide when compared to the general population. And so we know there is more that we need to do, must do, to support nurses and practice. And the third of my current role has been, of course, the COVID response, which at various times over the last 2 years has taken up more or less of my time. Very similar, I'm sure, to your own experience, both professionally and personally, as we've had to adapt in response to the pandemic. I held a particular role during the pandemic. So from March 2020, having been in the national post about 6 weeks, I was given, I think, what felt like an honour initially, and then at various points has also felt a real hindrance and a real weight to bear of responsibility, as I've been the clinical lead for the mental health response cell. And particularly in those very early days, it was ensuring the voice of the mental health nursing workforce was heard, ensuring that consideration was given to the needs of those with a mental illness, and then most importantly, or more importantly, ensuring the mental well-being of the communities of health and of particularly of nursing staff, given that we knew that it was likely that nurses would particularly suffer both emotional and physical in response to the COVID response. And what has continued throughout the 2 years and will continue for some time is I lead on behalf of the mental health team around vaccinations, infection prevention control, and particular any clinical policy that requires a mental health perspective on. So that just gives you a little bit of a flavour of what my day-to-day role is involved with. So you might be thinking, how did I get to where I am now, and what kind of roles have I experienced? And I know that on the webinar today, there's lots of you that are early career nurses and might be thinking about your own career pathways and where you want to do and how does it all fit together. I probably have a slightly unusual portfolio career over the years, and I've worked in a number of settings and places over the last 25 years that I've been a qualified registered mental health nurse. And I guess that is the beauty of nursing, is that we actually have the opportunity to work across settings, to work across geographical boundaries, and for some of us, work across those global boundaries as well, to really connect across given that we are one global health economy, one nursing family. So I very much started my registered nursing career working in the community, supporting people at home, enabling them to stay at home for as long as possible, and enabling them to really live a life that they wanted to lead, where mental illness wasn't preventing them achieving their goals. But I've also worked in prison settings, setting up the very first mental health in-reach services to prison. Of course, a major policy change, making me feel quite old now, back in the mid-2000s, where it was recognised and understood around the mental health needs of the prison population, and what an opportunity it was to support people in those settings in order to enable them to not only have good mental health, but also to support and enable rehabilitation once released. I've worked in high secure hospitals. I've worked across ambulance sector as a chief nurse, and currently I still continue to practice as a consultant nurse within a psychiatric liaison service down in Hampshire. So I very much always have wanted to keep my hand in nursing. I became a nurse to be a nurse. So although that my role now takes me into setting, influencing, supporting policy, strategic decision making, I very much also keep my hands on in terms of being at that point of care and still seeing and supporting patients, which actually has been incredibly important, not least in enabling me to recognise and stay in touch with the thing that I wanted to do in terms of nursing and what keeps me happy and keeps me getting up every morning. But it gives me the opportunity to see firsthand the impact that national decisions can have on the point of care, an opportunity to hear from people, patients, communities, and hear the ideas and support from staff, which really enables me to take that back into any policy decision or meetings that I then might be involved in. So just a bit of a reflection, and those of you that may have joined the previous webinar on policy that was led by Duncan, the Deputy Chief Nursing Officer, I stole one of his slides just to remind people around what is policy. Often it can sound something very stuffy that's done in a closed room, and what is then appears as a very lengthy document. But really all a policy is a set of ideas or a plan which should help guide us in a situation. And often it is guidance. So it's, we all have policies in our local practice, whether we work in a hospital ward, you'll have policy around both what to do in a fire evacuation as well as policy around sickness absence. So really a policy can be wide reaching. It can be around how we support patients. It can be about keeping us safe. It can also be around a set of agreed principles for a business and an organisation, government. So you can really have ward level policies which set out what to do in one given area, and then much more widely you can have national sets of guidance, and I'm going to talk a little bit about what they might look like, because when we're thinking about influencing policy, there is more than one type of policy or more than one way in which we can actually influence. And it's really helpful for those of you that perhaps don't feel that you have the opportunity to influence policy, practice, how things are done where you are, to really understand where you can make that change and make that difference. So, policy development. Now, what comes first, policy or practice? And I've been really thinking about this again myself when I was preparing for this webinar, because actually, particularly the professional nurse advocate, there wasn't a policy, it was an idea. And on implementing it, we then did the policy afterwards. So actually, policy doesn't always come first. Sometimes we imagine that people sit in a room, they come up with an idea, they plan how it's going to be done, the policy comes out and it tells you what to do. But actually, that's not always the case. Policy can come from something we've been doing in practice, it can come from research, it can come from an idea, and on the basis of that, policy can then follow and be changed. So when we think about particular government policy, it can often be in response to something as opposed to implementing something. So it's worth thinking about that when we're thinking about how we as individuals or how we collectively as a team can influence policy. Everything we do can potentially influence policy at some point, either now or in the future. And particularly I'm thinking about those of you that are interested in research. I noted from the attendance list that there are some of you that are doctoral students, for instance, And of course, the hope of any doctoral student is that your research is going to make a difference, and actually it's going to inform policy. And of course, in order to inform policy, we need to understand what the research says. What is good evidence for why we need to do something the way we do it? So of course, policy development can come from setting out a set of principles. It can come from evaluation. It can also come from research and your evaluations and the sharing of your ideas and the identification of gaps that need addressing. So how do we influence policy? And again, I know we've got a real mix of people on the call, and many of you may already be experts in this and already have extensive experience of shaping policy, both in your local team level, but also nationally, regionally, perhaps organisationally. But I really wanted to boil this down to some key principles when reflecting on what are the fundamentals of really being able to influence policy at any level, be it locally or globally, if that's your aspiration. And actually, the most important thing in order to influence policy is being interested, is having an interest, is being curious. It's finding out what's already out there. You know, does a policy exist? Reviewing a policy, is it still fit for purpose? And certainly in my experience, the first foray, if you like, into influencing policy was very much that reviewing of current policy. Does this still make sense? Is this still the right thing to do in these set of circumstances? Is there a better way of doing something? And if there is, how do I find that out and then implement that in this policy? It's also about listening, because it's not good enough just to influence policy and write a lengthy document. You need to make sure that what it says is the right thing, that it's going to have the right outcomes that we want. And we need to understand perhaps why current policy isn't working. So we need to listen, and we need to ensure that we are really listening, really hearing, and then really able to translate that into a policy that's going to lead to meaningful action and change. And one of the best ways that we can do that, being curious, that listening, is staying connected. And I've got some little pictures of mobile phones because, of course, in this social age, the way in which we connect has really been made far more accessible than it has in previous decades and generations. Certainly, I know that I am able to, with sensible use of Twitter, which can itself become quite addictive, really be able to link up quickly with like-minded people. I can quickly link with people that have developed policy in an area I'm interested in already, and connect and learn and share ideas with them at a touch of a few buttons. So really being able to stay informed, be curious, reach out, listen really is the first steps in being able to influence policy, and be aware when those opportunities come, when there are things like policy reviews, when there are stakeholder events to think about different ways of doing things. They are the first opportunities to really be able to influence policy at whatever level, both local, regionally, and nationally. So from a global perspective, what are the ways in which policy is already influencing, or how does policy draw on that learning from other countries and other ways of doing things? And I guess what I've always been interested in, because generally being a mental health nurse, we are known for our nosiness, otherwise known as curiosity, is really learning, looking, understanding what's working elsewhere. What is everybody else doing? What is it they're doing that we could actually bring here and learn from? And there are some fantastic examples already where we have adapted healthcare policy in response to healthcare changes, innovation, research, policy in other countries. And many of you on this call may already be aware of or involved in some of those things. Some of the examples that came to my mind when thinking about that global perspective was some, we might immediately think of the World Health Organization, of course, which really clearly sets out standards, recommendation, provides resources, draws together experts across regions to share ideas, to collaborate. But also there are other much smaller organizations One of them being TET. So I don't know if many of you have heard of the Tropical Health and Education Trust, which is actually based in Zambia. And they provide worldwide opportunities for volunteering, including for nurses and healthcare workers across the UK, to travel, to share, to volunteer, to exchange not only ideas, but also skills and competencies in order to reflect and change and take back and widen the healthcare knowledge. But there's also other examples of policy change that you may well have seen in your own practice. So New Zealand, after the natural disaster that they had probably 20 odd years ago now, their integrated care system that was developed in response to that, and their 4 levels of care, which really has patients at the centre, has really been showcased as an excellent example of how we should be working across systems with the patient leading in terms of needs. And of course, we could suggest that the integrated care system that we're now starting to implement across England is in direct response to that policy, that practice, that research change that came about in New Zealand. We also have the excellence models that several hospitals are pursuing, which we came out of the USA in terms of setting key strategies and systems in place in terms of supporting quality and thinking about how we demonstrate improvements in quality that also then convert to improvements in safety and patient outcomes. And for me, in my area of expertise around suicide, particularly something like Zero Suicide was born out of the work again in the USA around quality improvement, and the idea that by working collectively and collaboratively together, we can come up with ideas and solutions to improve care. And effectively, one of those was Zero Suicide, and more generically, the zero harm. But we also have other models that we look to shape our practice, such as Sweden and their community health models. And particularly during COVID, we very much look to our global counterparts to help us understand how to respond to a pandemic and to really understand what were the policy changes we needed to make in order to be as effective as possible. We've been really fortunate in the UK that we had, for many hundreds of years, probably since the flu pandemic after the First World War, had not experienced an outbreak of such a scale as other countries had in response to SARS and Ebola. And so very much at the early days of COVID, the first things that experts did was actually look to colleagues across the globe to understand what it was that we needed to do, what was the learning from them previously. And I personally connected, as did many nursing colleagues, with nursing colleagues across the globe to really understand what the impact would be, particularly for nurses. And certainly as the pandemic wave started to hit, firstly in Italy, we very much looked to colleagues in intensive care units across Italy to really understand what we needed to do differently and how we could support healthcare staff and patients to be able to survive and thrive during that time. So just thinking about policy into practice and practice into policy. So as I mentioned earlier, trying to think what comes first, and there isn't a steadfast rule about what comes first, because actually practice evolves all the time. We're continually learning, we're continually adapting, we're flexible, we're taught to be critical thinkers in nursing, and we're often thinking, adapting, reshaping what we do in response to patient outcomes, patient feedback, family feedback. And so sometimes there is a real divergence between what comes first in terms of policy or practice, and sometimes having a policy doesn't change practice at all. Again, in my professional practice, when things don't go as well, it is not unusual for one of the recommendations from learning to be people didn't follow the policy. And we need to understand well, was it the right policy? Did it contain the right content? And as I mentioned earlier, policies can be at local level, it can be at your ward, your community team. They can be regional policies in how to manage an outbreak, for instance. It can be a national policy review. And some recommendations, and I'm going to talk about a couple of those later, have actually been global. And again, COVID has really demonstrated the importance of that global health collaboration in order to really demonstrate rapid learning and rapid changes to practice in order to benefit patients. Research and evaluation has a really critical part to play in us being able to evaluate and critique both current policies to understand, are they shaping care in the way that we want them to? But also, are there any gaps? What's missing? What else do we need to do? What do we need to add? Quality improvement, and again, I'm sure many of you on this call will have been active participants, if not leaders, in quality improvement programs, is also thinking about what are those small changes, those incremental improvements that can be made to practice, which then can shift the way we do things and again, shift policy. And some of those examples of where we start to see the fruits, if you like, of research and evaluation around those formal policy consultations, such as NHS contracts, Mental Health Act, for instance, is also demonstrated within NICE guidance, who, when they have their call for evidence, their call for experts, will often ask for those examples that will really help shape policy practice going forward. And there's just a couple of examples there of just 2 sets of NICE guidance that I've contributed to in the last couple of weeks. Obviously, there is working for NHS England and improvement. We have a number of guidance, policy, implementation guidance too, which really helps to shape how things are done and to support practice and policy change on the ground. And I'm going to talk particularly about one of those with the professional nurse advocate. And of course, the other element that we tend to not focus on as much, in my view, is best practice. We're not always very good at showcasing what's really working, what we're really proud of. We tend to focus on what's gone wrong, but actually focusing on when things have gone well, that sharing of best practice, building the evidence base is also really critical when we're looking at reviewing policy. Again, both at local, national, but also at global level, when there is a call for evidence in terms of trying to do things differently. So that all sounds, probably very self-explanatory, and I probably haven't shared with you anything that you haven't already heard about, known about, done yourself. So I wanted to reflect on a couple of ways in which I have implemented policy most recently. And the interesting thing about this is that probably I wasn't thinking at the time about influencing policy. I was thinking more about influencing practice. And I think probably as a clinician that tends to talk to us more. Policy can feel quite dry, quite boring, dare I say, something that other people do in a back room. And when I've read policies, they can tend to be hard to read, overcomplicated, not really fit for practice, and incredibly lengthy and used as something against you when something goes wrong. So often my mantra hasn't been about changing policy or influencing policy. I've been much more interested in really understanding about how I change practice. And actually what I've come to understand is really, if you want practice to change, particularly at scale, particularly if you want practice change to be sustainable and recognised as sustainable, then policy needs to adapt, reflect and change with it. And that's probably something that I would say that I've learned much more in the last couple of years as I've been in this national role, and probably had less of an understanding of when I worked as a director of nursing and deputy director of nursing within trusts. And that may be just the way in which I have worked and the way my brain works, and not really connecting that. But as I say, for me, it was making that connection about what makes the difference. And of course, connecting in the real sense, if you want to change practice, it really is about connecting with others. And it comes back to what I was saying earlier about really listening, hearing, being curious and talking to others. So connecting became really important, particularly in the early days of COVID, when I was tasked with signing off, writing the clinical guidance for COVID. I wasn't an expert in that. I absolutely needed to connect with others to understand what was needed, but I also needed to understand what was practical, because what we might consider as being reasonable and practical when we're working in an arm's length body can be completely different on the ground. But I also recognised there was a need to be brave and to speak out, and that doesn't always come naturally. It certainly doesn't come naturally to me. To kind of upset the status quo, to perhaps step out of a mold and a role that you might have placed yourself in. And particularly during COVID and doing that clinical lead role, it wasn't usual for a nurse to take that lead role and really be leading around clinical practice. And that was quite scary at times, actually. And again, that's where the importance of having a network and connecting really sustained me in terms of surrounding myself with experts, actually, who could support me to make those decisions with colleagues that we hoped would have the best possible outcome. And one of the things I was really keen to do as an advocate for the nursing voice, and particularly wanting to elevate and ensure that the nursing voice was heard at the highest possible table, was actually being brave and putting myself in a position of vulnerability, of that huge imposter syndrome that probably many of us have, was to put myself forward when there was a call out to join the European division of the World Health Organization. So in that first summer of 2020, or the first summer of the pandemic, I mentioned to you earlier that we were really trying to link with colleagues across Europe, actually, and tracking where the pandemic hit first to really learn quickly from them what worked, what didn't. And collectively, the World Health Organization was pulling together experts from across obviously the world, but across Europe, to really bring together rapidly support, ideas, research, evidence, and collate that really quickly in real time at a pace we just haven't seen before. And I wonder if we'll ever see again, or indeed, I hope we never have to see again. And there was a call out for people to put themselves forward to be considered to join the technical advisory group on the mental health impact of COVID. And I didn't really expect to be successful, but I decided that it was really important to ensure that nurses had a voice at that table. And historically, the World Health Organization, from my perspective, didn't really have a strong nursing voice. And particularly, there wasn't a strong nursing voice coming out in those early days of COVID. And I thought it was really important, given the majority of care is provided by nurses, that we had a seat at the table and we were influencing at the highest level in terms of policy, practice, and future recommendations, because we're already recognizing that this was an opportunity. And that might sound a really awful thing to say in the light of the devastation that COVID has caused across our personal lives, our families, our communities. But it really was a wake-up call for many in understanding the mental health impact, not just of COVID, but the mental health impact and emotional burden, both of caring, whether that be in a professional capacity or personal, but also just how tough life is and how prevalent mental health illnesses can be. And yet in many countries across the world, mental health care continues to be inconsistently provided, and in some countries hardly accessible at all. So this was a real opportunity to influence from a nursing perspective, to influence from a mental health perspective, to share the learning from here in England and the UK, but also always more importantly, to connect and to collaborate with others, and also to learn from others about what works and what could work going forward, and how could we ensure that mental health care provision could come out of COVID and out of this pandemic better than it was before. So that building back better. And normally I hate a slogan, but it really does capture the real commitment that there was around the table of those mental health experts in using this as a time to really come together to make a difference. So I applied to become a member of the technical advisory group on the mental health impact of COVID-19. In those early days, it was still not very clear what the impact might be. There was some thoughts that children and young people particularly were likely to be impacted, given the impact on schools, on socialising, the impact that was likely to have on development. There was consideration that it was likely to have huge impact around those feeling isolated, lonely, and of course we were also acutely aware of the physical health impact and how physical health and mental health are so interlinked that actually if people are physically unwell, then it is likely to have a huge significant mental health impact too. So I was successful in joining the technical advisory group, the only nurse to be part of that group, and continues to be, I continue to be the only nurse. And from that work, actually what was launched was a set of recommendations, and that was from the technical advisory group in 2021. And that set out some really clear recommendations. Of course, they're very high level because they need to be recommendations that speak to and have relevance across a huge geographical area, which will need to have some local adaptations. But it recognised for the first time the importance and significance of ensuring good mental health across the general population and communities across Europe. So it also identified vulnerable groups, and I've mentioned there a couple around children and people, but it was also identified around deprivation, around accessibility, and we're really lucky in the UK that we benefit from a universal health offer that's free at the point of contact. Now, of course, that is not the case across Europe, although that remains a recommendation that actually mental health services, which are both community-based and inpatient-based, are freely available and universally accessible. And then the fourth area, which is an area which hadn't really had much place within World Health Organization recommendations previously, was identifying the impact, the mental health and wellbeing impact on health and the social care workforce. And particularly what was a key recommendation across Europe was that there should be mental health and psychosocial support offered to all health and social care workforce staff. And that should be an integral part, not just during this pandemic, but going forward in order to sustain a healthy workforce who are then able to sustain and support good and effective, safe patient outcomes. And some of the other things we spoke about, as you would expect, was ensuring access to PPE, ensuring access to vaccinations, ensuring access to sick pay, because actually all of those things that some of us might take for granted were not available across the European division. So I was really honoured to be a part of that technical advisory group and to be able to play a part, albeit a small part, in sharing the work that we were doing in England in those areas, the areas where we had done really well, such as vaccination offer to staff, and areas where perhaps we had been slow off the mark and perhaps we'd want to do things differently. We're also able to learn from other countries. I mentioned Italy, but also learning from Israel, and the work that they had done, from Sweden, from Denmark, the Netherlands, around different models of care, and particularly about how we support the mental health of communities. So moving towards prevention rather than crisis and intervention. But from that work, several countries agreed for the first time to launch their own mental health strategies. So Greece, for instance, launched, and you would have seen in the previous slide, the picture of Athens. Unfortunately, I was only able to attend virtually because of the COVID restrictions, but that was Greece for the first time committing to a mental health strategy for its people and its workforce. Out of that work that came from COVID, there is now a mental health collaborative across the European region. It is launching officially this year, but that will have three key aims, which I've put here. So transforming attitudes about mental health, so continuing to challenge stigma around accessing support when needed, stigma about what support should be there when available, and stigma which prevents healthcare workers also accessing support when they need it. Expediting mental health service reform, so there are many countries in Europe who do not have a community offer, where actually the offer is still inpatient only. So really thinking about how do we drive transformation. And of course, this year in England, we will also have a transformation of our community mental health services in light of that of other European countries who are actually ahead of us in that response. And accelerating progress towards universal health coverage for people with mental health conditions. So in England alone, those with a severe mental illness have a life expectancy of 20 years less than others without a mental illness. And that is something that is experienced across Europe. But where we have the benefit here of universal access, there is something inherent that prevents those people accessing that. So it's not only thinking about ensuring that universal health coverage, but ensuring the accessibility of it across Europe and learning from each other in order to shape policy, but also persuade and influence governments and spending to ensure that the resources are available to make that transformation happen. And because of the opportunity that was there to contribute, and I took it, I've been able to be a very small part in those decisions, in those discussions around shaping what will be European policy around mental health. But of course, I wouldn't be able to do that if I didn't have a network around me supporting, sharing ideas, influencing, shaping, feeding back, that enables me then to take forward within those meetings. And I mentioned to you earlier some of the things that I've put in place in order to support me in ensuring that what I'm sharing has relevance. The second piece of policy into practice is a kind of the other way around. So the World Health Organization work, I guess, fits more neatly into that influencing global policy that you would expect, accessing a credible global health organization, taking the opportunity when they call out for experts, and they do that very often actually, and I would recommend you having a look at their website, and those of you who are interested, looking at the opportunities to contribute, because they are there. But I mentioned earlier that sometimes practice shapes policy because the policy doesn't quite exist yet. And one area of that which I've capitalized, if you like, and policy has come later, and actually the global influence is now coming even later, is something that we developed in England in the face of COVID, but recognizing the need for change and a need for clinical professional leadership opportunities for nurses that COVID brought. And I want to share with you around the implementation of the professional nurse advocate role. So the professional nurse advocates programme really is an example, as I said earlier, of identifying a gap, identifying a need, being able to access research that supported the principles of the programme, being able to look across to colleagues, in this instance, midwifery colleagues who had already used a midwifery advocate programme, and really being able to draw that together in areas where I had already been able to establish some influence, this being as a clinical lead for the COVID response, and particularly thinking about the mental health needs of the workforce, but particularly nursing, enabled me to be in a position where when the opportunity arose for funding and ideas, I was ready with something to roll out. So the Professional Nurse Advocacy Programme is a master's level clinical professional leadership programme, and it was launched a year ago. So it was actually March 2021, towards the third wave of COVID. And this was a really critical point because we were still in the midst of some pretty significant pandemic waves in terms of admissions, mortality, infections, but also we were looking ahead to think about what are the changes that we will need in order to recover, restore, and actually sustain providing healthcare in the future as a healthy and competent nursing workforce. And the idea from having listened to visiting critical care units to continue myself in clinical practice, as I said, from learning and listening to colleagues, was there was a real impetus, a real commitment, but there wasn't the confidence, the time, the skills to really be able to take forward some critical areas that were needed in terms of transformation. And those 4 areas really aligned to what's called the A-Equip model. And those 4 areas which nurses, registered nurses, are trained as competent in a master's level programme are clinical supervision, a restorative clinical supervision, monitoring, evaluation and quality control. So actually understanding what are the markers for good. How do we know when things are going wrong? And how do I monitor and evaluate that and know when to raise the flag? Personal action for quality improvement. So what can we do differently? What would make a difference and how do I put that into practice? And then really understanding the culture and the education and the development and the culture of education and development in any setting that needs to be there in order to nurture supervision, to nurture quality improvement, and really support and enable nurses to be part of the transformation of care. So the Professional Nurse Advocate Programme was born, and initial funding was gained from COVID monies initially, and it was initially decided that it would roll out to critical care nurses first, because we had a small pot of money and it was based on some initial data we had around the mental health impact of COVID. However, I was always really clear they were just the nurses that we knew about, and that actually all the nursing profession could benefit from this programme. So I'm just going to share with you in the last few moments just some programme highlights and just some of the numbers involved in terms of really taking this forward. So this slide really, and I know it's probably very difficult to see over a presentation and hopefully be able to share this, but what we were really keen to do was to ensure that principles around universal access that we have for patients, for our communities, ourselves, around access to healthcare, I absolutely wanted to ensure there was universal access to this professional clinical leadership programme. But we also knew there were areas that would probably benefit from it earlier than others in terms of things like sickness absence rates, retention rates, violence rates, just some really key critical factors that we looked at. So there was a staggered programme of prioritising certain areas first, although the intention was always to have universal coverage across all fields of practice and all health and social care settings. So the programme just very quickly started. There was no policy, there was no national implementation plan. No one had ever heard of it, it didn't exist. There was not, or there were not any higher educational institutes who had a programme that was accredited at master's level to provide professional nurse advocates. The name didn't exist and no one had ever heard of it. And probably when I presented the plan to develop this programme back in the second wave around the Christmas New Year, it's probably fair to say that no one actually thought I'd be able to deliver on it. It was going to be for critical care nurses to apply for over that Christmas when they were pretty much on their knees actually, and we had the highest numbers of admission to critical care. And yet they came in their droves actually. And what this really spoke to was all of that foundation work around connecting, listening, being curious, understanding the research base, finding out the evidence about what could work really came to pay off. And with the support of colleagues, and particularly colleagues in critical care and the Critical Care Nurses Network, we're able to put together with the universities those early programmes starting in March 2021. The idea initially was to train 438 critical care nurses, which would mean 2 professional nurse advocates in every critical care unit, who would be able then to deliver restorative clinical supervision within their units. Now, the feedback from nurses in shaping this programme initially was they wanted something for nurses, by nurses, that would equip them with an academic, credible qualification, and which would enable them to be seen as valued, critical nurses in order to shape and influence and lead clinical transformation as part of the recovery restoration. So that really was the background to this model. So March 2021 was the first cohort of critical care nurses. And additionally, I had a separate cohort of mental health nurses too, because as a mental health nurse, I felt I had to ensure that my field of practice was also represented to test out this model within a different sector. So since then, it really has taken off a mind of its own. And the only reason that this has been so successful is because it has really struck a chord with the nurses who are now delivering as professional nurse advocates. And I really had identified the gap in policy, because we had clinical supervision policies, but what the gap was a model for clinical supervision. What the gap was about consistent accredited training enabling people to deliver. The gap was understanding the benefits of understanding cultures of leadership and development in being able to sustain environments of quality improvement. So this really fulfilled a gap in policy, it filled a gap in practice, and it absolutely filled a gap in what nurses said they wanted. So in the last moments of today's webinar, I was going to share with you some of the things that have been put in place around this particular programme, which is now having shaped local, regional, national policy in England, is now being looked at globally from several other countries, including Scotland, Wales, Northern Ireland and the USA, as a model that they would like to take in terms of shaping their policy and practice. So this is an example of an idea, if you like, shaping policy, starting here and beginning to shape global policy. So we now have just under 3,000 nurses. This was at the end of January, so that number will have increased, but we will have over 5,000 nurses trained as professional nurse advocates by the end of this financial year. We now have the National Professional Nurse Advocate Implementation Guide. So the policy wasn't actually published until December 2021. So we had to work outside of a policy, building the policy as we went, if you like, because this role did not exist. We developed the e-learning modules to support the policy implementation and to support the programme, and they went live on the 17th of December. We also have committed to an economic evaluation and also a qualitative evaluation to build the evidence base for, does this work? Why does it work? How does it work? And who does it work for? So that we can continue to shape and influence both policy, implementation and practice. And other policy changes have happened in accordance with this. So as this programme has developed and really gained momentum, we've changed the NHS contract. So there's another example of how policy has changed and adapted in response to programmes of work. We've also submitted to the NICE guidance to change policy around best practice around supporting the health of the workforce. So this is an example, as I mentioned, around how what you do in practice can then shape policy in response, as opposed to always waiting for policy to change and for you then to implement it. So the next steps, as I mentioned, the ambition will be, and this is now enshrined in the NHS contract, ready for April 2022, is 1 in 20 registered nurses will be trained as professional nurse advocates by 23-24. So we'll have around 18,000 professional nurse advocates trained across all healthcare settings, including general practice. So I'm sure there's probably quite a few questions around some of the sort of global work around World Health Organization, and I could have told you all about all of the sorts of other places that I've been able to visit and steal ideas and share that have then implemented various policies over the time of my career. But I guess what I've hoped to have been able to share with you and shape are a couple of examples of how I've personally, professionally, been able to take advantage, if you like, of opportunities, to reach out and create opportunities in order to shape practice that then has inevitably shaped policy nationally and globally. So my top tips to those of you who are perhaps thinking about changing policy is be curious, continue to connect and network. There are some fantastic resources out there. There are some fantastic webinars that are run around World Health Organization, which have opportunities to connect. The International Congress of Nursing, Florence Nightingale, I know, has new global policies. There are fantastic opportunities. There are travel scholarships. Take those opportunities as they arise. Recognise that we have as much to share as we can learn. We're not always very good at sharing our good practice. We're very quick to say what we're doing wrong, but actually we can only learn and change and adapt policy if we know what's working. Policy is only relevant if it translates into practice. That's my personal view on this, that actually there's no point having a document that sits in a corner rotting away unless we really know how it's going to implement and change practice. So I really want you to think about, when you're thinking about policy, actually what difference this is going to make and how are you going to do that. And finally, the reason that I've been able to shape policy in the way that I have to date is because I've had the support, the network, the listening boards, and the contribution of others. And one of the things that I'm always really grateful is the opportunity that others have given to me to have my 10 pence worth and to shape policy. And so one of the things I was really committed to ensuring any big policy changes was that it had the opportunity for others to contribute to, hence building, as I mentioned earlier, those networks of nurses who can help shape policy at whatever level they wish. But I shall pause there because I know I've only left 5 minutes for questions, so apologies, Lucy. But thank you very much, everyone, for listening. Not that you had any choice, as this is not participatory, but I hope that's been helpful. Thank you for listening.
Thank you, Emma. Thank you so much. And there has been a lot of questions coming through, so we'll try and get through as many as we can. But what an informative
to take them
webinar.
Afterwards and share the answers.
Of course. Well, I think there was a couple of people asking for your contact details, so I think just those people who popped that in the chat, there's Emma's email if you want to get in contact with her. Please do drop her a note. She's also on Twitter as well, so there you go, Nursing at Emma. Like, if you follow me on Twitter, Emma and I are connected, so I'm sure you can find she's linked on my latest post on there. So, God, key takeaway, absolutely be brave and speak out. I really did like that, Emma. It's so important, and the power of the network. I think we certainly know that Florence Nightingale Foundation, what you can achieve together by collaborating. So thank you. So I'm just going, without further ado, going to go to some of the questions. So Mike Fanning has asked, do you think the P&A role will translate across the emerging ICS system?
There's no reason why it shouldn't. And the reason I say that is because it's 1 in 20 registered nurses, regardless of where you are. So we already have really good representation across every setting, which will inevitably include ICS. And the way that we've established community, I say we, it's a real we, because I haven't done this, it's the nurses themselves. They have established communities of practice, which are not in the normal geographical work-based pathways that we've seen. They actually are already integrated, and the way that the courses were taught was integrated as well. So the first time it was mental health community nurses working with critical care nurses, working with GPNs. So there has been a bottom-up approach, if you like, to working across settings already, which should ensure that that P&A role is really embedded. How that looks across the ICS beyond the local level delivery, I think, is something that we're still thinking, building, influencing, and there's still the opportunity to influence. But from what I have seen already, and the feedback from those that have completed the course, is this is relevant wherever you are. And I know that this morning I was contacted again about social care, because there is no reason why this cannot go across to social care either. So I think absolutely yes. How? I think there's still some work to be done, but the foundations are there.
Great, Emma, thank you. And that answers some of the other questions on how do you implement this locally. And a couple of people wanted to get in contact to pick your brains for further information, so obviously you can share. We've got that contact details there. I've got a question here from C. Kelly, and she's a safeguarding lead. She said, obviously, I used to in a previous life too. So if you learn from serious case reviews, and that's how you kind of implement changes. So many lessons have been highlighted before, and actions either not been implemented or aren't workable in practice. So really important question. She's interested in interested in how we can better implement and drive forward policy changes that actually workable and practical.
It's a great question, actually, and I think I mentioned it actually in the talk, that often what happens when you have a critical incident review, and unfortunately I've been involved in many myself, it will talk about changes to policy without really understanding what is it about the policy initially that didn't work, and why would a policy change make a difference. There is some national work underway actually about how we make changes in response to any incident, but I guess for me there's also something about really understanding what works, and really focusing and ensuring policy reflects what works, not trying to mitigate always what doesn't. And I know that probably sounds a bit of a difficult question, but I think it's a much broader conversation to be had. But often policy training can seem like a really quick win. If we just did this differently, practice would change. And we know that actually we're human, we're individuals. There are lots of complex things happening, and we need to think very much differently about the systemic causes of why policy can't be implemented, and the systemic systems and culture that needs to be in place to encourage that. So a great question, but I'm not sure I've got time answer it all the answers either.
Yeah, unfortunately not. We have run out of time today, so I do apologise, everybody. But there's Emma's contact details. I think the big thing is to be bold and speak up, isn't it? If you feel that something needs to be changed, be bold. And it's not always, as Emma said, it's not always easy for us to do that. But please be bold and raise that nursing and midwifery voice. Like we said, there will be, it's been recorded today. It will take a couple of weeks before it's available because it needs to go through an approval process. But as soon as we have that, let's share that with you all. Just a huge thank you, Emma, for sharing your expertise and your time with us. It's been a real privilege to have you with us today. So thank you. And Emma is kindly available to answer any questions if you want to contact her directly. So thank you, everybody. Have a really good rest of the afternoon. And again, thank you, Emma. Thank you.
Thank you for having me.